It's time to get the story behind the story. Interviews with newsmakers, news breakers, and Vermonters making a difference. WCAX presents 802 News with Mark Johnson. Here's Mark.
The state's top healthcare regulator and some activists are cautiously hopeful after Vermont's largest healthcare network announced this week significant cost reductions. The announcement of layoffs, scrapping bonuses, and other cost-saving measures by the University of Vermont Health Network comes just ahead of hospital budget review hearings before the Green Mountain Care Board, the state's regulatory body. The health network oversees 3 hospitals in Vermont, including the largest, the University of Vermont Medical Center in Burlington. Regulators and activists say the network will need to make even more reductions in the future and that the state's entire healthcare system needs significant changes and realignment to save some of the smaller hospitals from closing, to shore up the finances at the state's largest health insurer, Blue Cross Blue Shield, and to provide relief for Vermonters who are paying some of the highest healthcare premiums in the country. In this edition of 802 News, sponsored by Red Hen Baking Company, I spoke with Owen Foster, the head of the Green Mountain Care Board, about Vermont's precarious healthcare system. The good news, he said, is Vermonters are more engaged than ever about finding solutions, but he also worries about recent federal legislation that includes Medicaid cuts that will add more pressure on the system, particularly for those already struggling rural hospitals. We'll also hear from Chris Pearson from Vermont Healthcare 911, a coalition trying to pressure the UVM Health Network to reduce costs. Pearson is hopeful, but also skeptical. The network's shift away from challenging regulators will be permanent and isn't just temporary. We begin with Green Mountain Care Board Chair Foster, who I asked to comment on the network's estimated $185 million in cost reductions outlined earlier this week.
Yeah, generally speaking, my reaction was it's extremely painful for those individuals and those families that are affected, obviously. Unfortunately, we're in an environment in healthcare where there's going to be hard decisions, and UVM made a very, very tough decision. I think that they recognized the affordability component and the sustainability component in making that decision, and they clearly targeted the reductions in areas that were non-direct patient-facing, right? So my understanding is there's no providers that were let go, and it was largely, if not entirely, administrative positions. My other reaction in reviewing it was these were largely areas where UVM appeared, at least to the care board, to be over-indexed as compared to peers. So it was an area where it looked like there was opportunity to reduce expense.
And so you're not concerned that these positions, unlike previous reductions that they've made, which did seem to be targeted more towards patient care, that you're less concerned about that than you were a year ago?
Yeah, certainly. So when UVM made the reductions in dialysis and inpatient psych and primary care, those are really sensitive services and really essential services to people. So yes, I mean, if I look at it, I think that these are much more prudent and consistent with state goals as opposed to the dialysis and inpatient psych.
Would it be fair to say that the mood, the reaction between the UVM network and the Green Mountain Care Board has changed?
I think it's always changing. We are working much more closely with them in a way that's different than we have before. So we have a role as a regulator, and we can't really go outside of the bounds of the regulatory process while we're in that. However, in terms of like longer term, bigger picture, strategic planning and state goals, and UVM's operations, we're much more closely aligned than we ever have been. We have work group meetings that occur every other week to once a month, including some board representatives and UVM board members as well. So yeah, I mean, the dialogue is much more fluid, and I think we understand each other's positions much more than we ever have.
Well, last November, the UVM network was blaming the Green Mountain Care Board for the cuts and the concerns about patient care. That seems to have changed. I mean, would it be a stretch for me to say that from the outside, it looks like it's gone from contentious to more conciliatory?
think that's somewhat fair. I don't know that I ever considered it necessarily contentious. I mean, they had a view and we had a view and we had to make the decisions we wanted and they had to, but I can understand the outside perception seeing it as contentious. We have a role that includes a context well beyond one hospital. It includes many other facets. And when somebody's looking at it from their prism and their context, it's hard to understand why someone would disagree, right? I think I told you this little, anecdote when I was in AUSA. I always thought I was going to win a case until I heard the other side go. And I think it sort of parallels this in that we made the best decisions for the state. And sometimes it's hard for an individual entity to understand. But I think through a lot of work in breaking down some barriers and walls, we and UVM have understood each other's perspectives in a different way.
What happened? How would you describe that more coming together? What happened?
Yeah, good question. I asked someone for advice on how I could work better with UVM, a legislator, in fact, and they gave me some advice on how to try and approach it and change the course. And then I reached out. UVM was over a number of budgets by a significant amount. And I said, I think we need to deal with this in a different way. Their board chairs were directly involved immediately. So Tom Galanka, the chair of the Health Network, Natalie Richards, the chair of the Medical Center Board, became personally and intimately involved. And I think that changed it a little bit. And I think just having a number of hard conversations for a period of months really helped. I think just opening the doors to conversation and understanding was a big, big change. I'm not saying it's perfect. Like we definitely still disagree on many things and we will continue to. But I think at least there's a respect and understanding of where the other side is coming from and roles. It's not, we don't work with them necessarily. We want to, but ultimately we have to make decisions. And I think we've broken down some walls in a healthy way.
What was the advice you got?
To reach out and to try and to just start conversations.
And that was different than what had been happening before?
Somewhat. A lot of how a regulator works is it works through its public hearings, and that naturally has sort of a raised tenor to it, right? I mean, we're a quasi-judicial entity, so we're asking questions and they're on the spot. It can make people feel targeted, right? Like we have to probe, have to ask hard questions. That can be taken from the person receiving those questions in a tough way. The other difference is we typically do our work through written opinions. So we write an opinion and off it goes. Not everyone reads those opinions, right? So if you're a board member, maybe you read it, but maybe you just get an update from management without the full explanation. So I think is really trying to break down barriers on both sides and to work together. And I'll give their board members credit for really working hard. They put in a lot of time to try and get on a better path.
It's interesting because I thought when you said about written decisions that what you were going to say is that when things get reduced to the black and white on a piece of paper, you lose that nuance of people having a face-to-face conversation.
I think that's ordinarily true, except our lawyers are such skilled writers that I don't think that happens.
Touche. Good answer. You mentioned that the network had gone over budget, roughly $90 million for the past couple of years, each of the past couple of years. And you came to this agreement, which seemed to get mixed reactions. Having said what you just said, trying to create a spirit of working together, I think I better understand why you did what you did. But, there were people that felt that the agreement that you reached with them was too soft.
Yeah, there were, and I understand those arguments. There's other people who thought it was way too harsh, right? There's people who thought it was underfunding UVM and how could you do that? And there's other people that thought it should have taken out more money out of UVM. For me, in hindsight, now several months after, I think it was one of the better things we've done. And I think it was really prudent and balanced. Our job is not to be punitive to UVM. It's to do the right thing for the state. And I think there are people in Vermont that I think fairly have a lot of distrust of UVM. I think that that's something that UVM needs to continue to work on is rebuilding trust throughout the state. And from those people's perspective, I think they would have wanted to see something stronger, sharper, harsher, more quick. But from my perspective, we need UVM to be a good hospital and a strong hospital and a keystone of our healthcare sector. And I view it a little bit more as like a long-term game. There's some really important short-term things. There was press about UVM's prices going down 7% this year. That's an enormous difference. Not many hospitals are seeing that kind of reduction in 1 year, and that's because of the settlement. On top of it, I think having Mike Smith as a liaison overseeing some of the operations and being a sounding board for their management of their board is immensely valuable. He has a tremendous team, and he's able to bring a different perspective to those meetings that he has with management and with the board. And then third, the money that we use to shore up Blue Cross has immediately paid dividends. I mean, Blue Cross was in real financial challenge situation. And we also were able to achieve an $11 million support for non-hospital primary care. Those two things, shoring up primary care and Blue Cross, are immensely, immensely valuable to the state.
I want to get back to Mike Smith in a moment, but let me ask you about Blue Cross Blue Shield. How are you feeling? How confident are you feeling these days about their solvency and their financial health?
So we have their rates before us right now with decision coming in 23 days. So I can't get too deep into it. I think in 25, things are not going down as much as they have been. So I still feel very, very concerned, but it's not on the same level of downward trajectory as it was. That's still a potential out there, but it's not dropping like it had been.
After your board made its enforcement efforts against the network, Mike Smith was one of those who was very critical when they cut patient care, and said that it had been done recklessly and in a haphazard way. So that signals to me, given what you've said before, that there really has been quite a shift in attitude on the part of the network.
Yeah, I think that's fair. I mean, if you look at these reductions and how it appears to be approached as compared to the ones in the fall of 24, it's very different. And I think part of that is the dialogue we've had, their board members' involvement, and I think probably also Mike Smith's involvement. And maybe just, in hindsight, they looked at what they did and they didn't like how they'd done it. So kudos to them for course correcting.
Yeah, I guess Monday morning quarterback probably isn't all that helpful, but when I look at some of what they're talking about cutting now, cutting bonuses was something that was very contentious, deferred maintenance, trying to reduce the number of tests, trying to cut back on the traveling nurses, leaving a lot of these positions vacant and not filling them. That just sounds a lot less inflammatory than cutting dialysis, mental health, and kidney transplants.
Yeah, for sure. I mean, they didn't end up cutting dialysis. They had continued to do it, and then the board made an adjustment to ensure they continued to do it. But that put a lot of patients in very stressful positions, right? These are dialysis patients, and the information they had was they had to figure out something else. And that causes a lot of sleepless nights for very sick people. I think that was highly inappropriate. I cannot condone that. It was wrong and it didn't need to be done. And so I'm glad that that's not how this was approached in terms of these most latest reductions. I think as I look at the whole state and the healthcare economy we have, there's going to be a layer of administrative cost reductions that are possible at a number of hospitals, maybe even all hospitals. That's kind of the easier stuff to deal with. And I'm glad that that's underway because it's necessary, if not painful. But then there's another layer, which I think UVM had alluded to, which is increasing efficiency and cutting down on waste, reducing length of stay, reducing ED utilization, reducing borders, increasing provider productivity, turning over surgical rooms quicker. That's like the next layer that's very critical to get to, that's very costly. That's a huge amount of money, but it's not as easy to get to because it's cultural. And so that's harder to get to. And then there's still yet a third layer the state has to grapple with, which is transformation writ large. What services are where? And that's a complicated and hard analysis. So there will be service line changes throughout the state. And the challenge is getting it right to make sure that we balance affordability with quality care.
I've been trying to add up these numbers because the network says that its savings are about $185 million. Does that number ring true to you? I mean, I've got, 5 million in the layoffs. There's 7 to 10 million in the bonuses, 70 million in deferred maintenance, 60 million in reduced tests, et cetera, 30 million less in traveling nurses. Do you feel confident with that $185 million number?
I haven't done any sort of audit or anything of it. I've just seen the press release and read it. It seems like some of it is potentially aspirational. For example, you mentioned reducing unnecessary testing. Well, that's not something you've done that you can bank. You have to do it. Minimizing inpatient and ED stays, that was another one. Again, that's similar. You have to be able to effectuate that to achieve that savings. But directionally, yeah, I think there is a huge amount of money that we can reduce. And I'm glad that UVM's holding itself accountable, right? They put it out there and they said, here's what we're going to do. So I think that's important right now.
Is it going to be enough?
No, it won't be enough.
Tell me more what you mean by that.
Well, if you look at it depends on how you define enough. And the way I define enough is what can Vermonters afford? And we do have some of the highest healthcare costs in the country. The premiums are some of the highest in the country, and our total per capita spend is some of the highest in the country, if you include all payer, right? So there's really no ability to go up higher. People just can't pay it. So if you define enough that way, these reductions won't be enough to ensure that we have premium increases around 0 to 3, 4%. That would require deeper look at the footprint of the network and the footprint of the state, right? We have to look at, are we filling the community's needs for mental health and for substance use and long-term care? So that's that third layer I was talking about in terms of transformation. So no, it's not enough.
The cost of insurance seems to have really spiked in the last 5, 7 years. Hospitals are spending 50% more last year than they were 5 years before.
Yeah, I mean, certainly the cost of insurance has skyrocketed. I have the exact numbers. I don't want to quote them off the top of my head, but we've about doubled our premiums in the last 5 or 6 years. And most of that does correlate to the quote cost of care. When those insurance rates go up, it is overwhelmingly driven by medical utilization and medical costs, right? So how much we pay and how much we use. So those do track really, really, really closely. When we do our insurance rates, the 90, 94, 95% of it really is related to the cost of claims themselves. And as Blue Cross went down, it was really because of the cost of claims. But when you peel back the onion, if you say cost of claims, care is more expensive, it is more nuanced than that. You have to look at where the care is, and is that where it needs to be? So for example, if you get a colonoscopy at UVM versus Green Mountain Surgery Center, it's significantly more expensive. Similarly, if you get imaging done at UVM or at Rutland or really most any Vermont hospital as compared to open MRI, it's a multiple, right? So the other thing is when we say more utilization, well, more utilization of what? Is it more utilization of testing? Because you can order a test in Porter and then at UVM and then at Brattleboro, and yeah, you have more utilization. Is it appropriate utilization? Is it what we need? That's a different question, a more nuanced question.
When you say that the cost of care as a state needs to come down, in most businesses, the first round of savings is a lot easier than the second, third, and fourth. So is it what you just talked about, where you get the test done, for example? Where is this next layer of reduction? Where can that come from?
Yeah, you're exactly right. And from where I sit, I think that next layer is really, really, really difficult. It does come from providers working and thinking differently. So historically, if you ran any entity, your goal is to maximize revenue and grow revenue and grow your business. Well, if the hospital maximizes revenue and grows its business, the insurer goes the other way and affordability goes the other way. So we have to really deeply change the mindset. We're not trying to grow hospital revenues as much as we possibly can. That's very inconsistent with what we're trying to do as a state. So that next layer is administrative and operational efficiency within the four walls of the hospital. That is one thing. If you have a doctor seeing one patient an hour versus four patients an hour, it's more expensive to have those surgical rooms sitting empty or to have more physicians to provide the same number of patient services, right? So room turnover, length of stay, all of those things. So there's within the four walls of a hospital, but then there's the external part, which is, should we be delivering this care in a hospital? And that will be adverse to some hospitals' financial interests because they make a lot of money on an MRI. But what I'm saying is that's really expensive for the state to do it. And it's a bit of a service that you can provide in any number of other settings with extremely high quality and great outcomes. So we need to shift some care to other places. I'll give you a real quick example. Tick bites. A lot of people go to the ED for a tick bite. You can do a tick bite and get it treated appropriately in your primary care office, in an express care, urgent care, any number of settings, and it will cost a fraction of the money. So part of it is, and then that third layer really is, what's the mix of services we have across the state and where are they? Because if you have services at every 14 health service area with really low volumes, that's very expensive. You'd rather have it near, capacity or closer to capacity in 2 or 3 rather than 14 at a much lower amount.
How do you shift that? So how do you get the emergency room to say to a patient, to say to me, I'm not going to treat you today, go to your primary?
Yeah, difficult. There have been steps made. So one is you have to have the primary available. And in the state right now, we have a shortage of non-hospital primary care providers. We need more available. And they need to have appointments you can get, or you need an urgent care and express care in your community. So part of it is building that kind of infrastructure, which doesn't happen overnight. But in the short term, we need to make sure we support the FQHCs and the non-hospital primary carers so that they can be there to provide that service. There have been steps a number of hospitals have made, like notices to people, hey, our ED is super full today. Please go somewhere else. If you have this or this or this, consider going to a different facility.
Go back to the whole system here. There was this report that came out that was pretty dire, talking about a number, 4 of the smaller hospitals really being on the financial ropes. What's that situation like today?
Arguably worse. I think the Oliver Wyman report, they had found 4 and their conclusion were at immediate risk. There's been some national publications that have echoed that, around 4 to 6 that are in immediate risk. If we look at the finances from today as opposed to a year ago, they have deteriorated a lot. Days cash on hand is down. The operating margin losses are steeper and deeper. And at the same time, we now have the big, beautiful bill that was introduced. That'll create a whole nother layer of complexity and the loss of enhanced subsidies potentially on the QHP market. That will drive more people off the insured market, potentially thousands. That will really challenge those hospitals' finances. So I would say that I would say, if anything, the Oliver Wyman report was perhaps optimistic.
Then how are these places still in business?
A number of them have implemented recovery plans and are implementing new strategies, cost containment strategies, trying to make sure that they can remain solvent. They're not out of the woods by any means, but they're fighting and battling day by day to ensure that they have the right services for their community. We'll see. I mean, you have to keep in mind, this isn't uniquely a Vermont problem. I mean, hundreds of hospitals in the nation have closed. UVM's reduction is a big headline, and appropriately so. That's something that Boston hospitals and Dartmouth have dealt with 4 years ago, 5 years ago, 3 years ago. This is not just us. We're in some sense a little bit late to some of these painful parts, which is maybe a good thing, but maybe a bad thing. We're getting it kind of all at once.
Go back to where early on here, you talked about your confidence in the leadership and the board of trustees of the network. I mentioned to you, I've recently talked to some folks with this advocacy group, Vermont Healthcare 911. They were very critical of the UVM Health Networks board, didn't feel that they had done a good enough job overseeing the management executive director of the network. You disagree with that?
No, I mean, I think what I was speaking to was really that you were asking about the relationship and the change in course, and that I thought that some board members really stepped up, and that was a big component to it. I think governance in a very large hospital system is really challenging. If you look at the network board, it has a lot of people from various interests and it's big. It's 23, 20 something people. That's really hard from a governance perspective. And there's people, it's hard to make sure you have the right layer of governance. Governance necessarily will rely on management. I have a board of 5 and it's difficult in a good way, but 23 is really tough. And I think probably 911 is alluding to historical things, right? I think they were alluding to probably the growth in UVM's commercial revenue, the growth in UVM's operating expenses. I think from that perspective, they're right. Those are really extreme, and now is a challenge for them and for the state. And at the same time, I understand and I agree, frankly, with some of the criticisms about the executive compensation. I think there was a lot of criticism from that group and others about really large bonuses being paid out in years when there were really painful reductions in patient-facing care. I agree with those criticisms.
One of the other questions that some in that group have raised is a concern that the network could be sold to a hedge fund. I'm really kind of simplifying this. Is that a legitimate concern? And is that something that you've thought about, anticipated, and are trying to figure out a way to deal with?
I have to be honest, I haven't really delved into how much of a concern that is. Unfortunately, things are pretty hectic right now, and I'm focused on really immediate short-term issues. We dealt a lot with our legislators on a number of solutions this year that I think are important. I think one of the bigger things, big picture, like even it would address that in that governance question, is ensuring that the boards and the management are aligned with the state mission rather than just our mission. Our mission might be we want to give the greatest care on earth to as many people as possible, and we want to grow revenue to do it. Well, that might not align with the state mission. And maybe that's where I think governance can be improved, is making sure that what they're evaluating their executives on is what's best for the state, not just that one entity. And that's something that we did work on with UVM in the settlement agreement. It's actually a term that they had to change how they compensate their executives to align with the state's healthcare goals.
2 other questions. Basically, it's one question. I'm thinking to myself, listening to you, how you're not thinking about this at 2:00 in the morning. So what's giving you the most hope right now? What's your biggest worry right now as you head into this sort of critical week here?
Well, one, I have to be honest, I worry about the people who are losing their jobs. That is something that's really intimately painful for those families. And I know it's necessary and the right thing to do, but I do worry about those families. Big picture, I'm most encouraged by the level of state awareness and engagement in the healthcare issue. Some of the actions the legislature took this year were really bold and really impactful. And we already saw that with the drug price cap bill and the potential impact on rates, hugely enormous for Vermonters. So the state engagement and awareness is at a level I don't think that there's ever been, and many people are coming forth. Mike Smith, the legislature, the governor's office, AHS, DFR, industry, there's a lot of people who are now answering the call. I don't know if we've executed. We have a lot more of execution to do. I guess that's what keeps me up is, are we going to be able to do the transformation we need to on the timeline that we now have? We all thought we had more time. With the federal changes and the financial realities we have, we might not have that convenience, and that's what keeps me up.
After the break, we'll hear from Chris Pearson, a former state lawmaker who is a member of the Vermont Healthcare 911 group. First, this. At Red Hen Baking Company, they believe pure, uncomplicated ingredients in the hands of skilled artisans are the building blocks for great food. They're dedicated to creating the best food from the best ingredients. You'll find an ever-changing lineup of delicious pastries, sandwiches, and soups at their beautiful cafe off Route 2 in Middlesex, just off I-89. Their breads are also available in many other locations. Led by owners Randy George and Eliza Kane, Red Hen Baking Company has been on the leading edge of the local food movement since 1999. We begin with Pearson's view of the reductions proposed by the network.
It's a significant change of tone from even 8 or 9 months ago, when pressured by the Care Board, and then they cut services. So that's welcome. Vermont Healthcare 911 looks at this as step one. It's good to see that step, but we're more interested really in step 2 through 10, I guess. This is a significant change of direction and a first small step. What will be interesting to see is whether or not they consider this the beginning of a transformation. Where is the real structural change and the commitment to being a high value, high quality system? This hopefully is step one in several steps of that process. That remains to be seen.
Why do you think there's been a change in tone?
Do you mean what do I see as a change, or what makes me believe there is a change?
Why do you think it happened?
I think last year when the Care Board gave them less of an increase than they wanted, the medical center and the health network reacted very poorly. They cut services. They blamed the regulators. There was no self-reflection, no ownership over the fact that they're a high-cost system, top-heavy, that they're, bringing in a lot of money and boosting their own reserves. There was none of that. It was all sort of an external, like my kids, it's somebody else's fault. You're seeing here at the beginning, as I say, Dr. Epen has been on sort of a PR tour trying to explain that they recognize the affordability crisis. They recognize that they have a role to play. That's a significant change. And it is, in fact, backed up by a budget that is more in line with what the Care Board is demanding, some position cuts. It's a small step, though. This is where I want to be cautious. So you're seeing a shift in attitude. It's moving in the right direction. We got a long way to go, and the follow-up will be kind of more interesting. But I give them credit for an important first step.
Okay, but what I ask you is, why do you think that happened? Why do you think they changed?
I think the reaction to the 2024, the fall of 24, the health centers and medical, I think the reaction to the 2024 budget order in the fall of 2024 was poorly received by the public. They cut dialysis, they cut mental health beds, and tried to blame the regulator. The public reacted poorly to that. They were not impressed. The legislature was not impressed. That news of those cuts was quickly followed by the fact that Dr. Epen and other executives were getting significant, I guess we're not to call them bonuses, but millions of dollars in extra pay. That created a bad environment. And I do believe that the health network's board of directors and leadership themselves recognized that it was not a smart move, and clearly they seem to be taking a different posture. So I think there is some I like to think there's some recognition around the affordability crisis in our healthcare system. I also think their strategy in the late 2024 did not work well, and the public reaction was strong, and so they seem to be trying something different. And I'm a guy that's been asking them to try something different. So I do appreciate that, and we want to see what the details are, better understand them, and also see what the follow through is.
When you say there needs to be steps 2 through 10, That sounds like a lot.
Yeah, I mean, I think, look, we have our hospital system and our healthcare system in Vermont is in real trouble. We are at risk of losing rural hospitals. We're at risk of losing our largest insurer. Literally, I mean, Blue Cross Blue Shield could shutter. That is kind of unimaginable. We have a very expensive hospital system. This is not going to change overnight. But to me, what's required is not just a trimming of some excess personnel here and there, and a small reduction in charges to commercial insurance. What's required is a cultural shift where hospital leadership works with regulators, works with this panel that is being led by Mike Smith, and says, for instance, how do we join most of our colleagues in other academic medical centers around the country who can break even or make money on Medicare? As a very concrete, straightforward example, 2/3 of academic medical centers break even or make money serving Medicare patients. The medical center at UVM is losing about $119 million a year on Medicare patients. And then when we point this out and complain that that's one of the reasons they explain high commercial rates, they say, well, we have a lot of seniors in Vermont, and they're expensive, and we don't get paid enough by Medicare. It's sort of a head scratcher, and you go, well, if that's true, which it is true, we have a lot of seniors, shouldn't the goal be to break even on Medicare, not continue to run up the bill on commercial insurance? So that's what I mean when we say there needs to be this cultural shift. There are good examples out there around the country. There is something called the Medicare Break-Even Project, as an example. It's been very successful out of the University of Cleveland. So I think, though, the first step would be a commitment from hospital leaders to really change the culture and roll up their sleeves, work in partnerships with the Green Mountain Care Board and any others, including my organization, to figure out how we can build a truly sustainable, high-value, high-quality system.
I, as you know, spoke with two members of your group a month or so ago, maybe even a little less, and they expressed some real concern about the leadership of the board overseeing the network. Has that changed? Your group met with them. How is your feeling about that leadership?
That's a good question. I think we were pleased to get some time with the executive committee of the UVM Health Network. Appreciated them meeting with us on fairly short notice and starting to talk about some of these issues. We had mixed results in that conversation. I'd be honest and say there did seem to be an understanding from the executive committee that there was a crisis in affordability. They did seem to understand that there needed to be a different tone coming out of their own staff and hospital leadership, as well as, from them. But there was, I love them to take more ownership over the current system. They are by far and away the leaders in the hospital system, and I'd love them to act that way. There often is a tendency that I hear of them to sort of look at their own numbers. Isn't this reserve, our building reserves good? That means we have a strong health network. You need that. We do need that, but you can't have one entity, putting cash aside while the rest are kind of really struggling. I mean, you've got rural hospitals that are struggling. Blue Cross is struggling. The health centers, our community health centers, FQHCs, are struggling. This is part of a system. I'm not seeing from the UVM board of directors, the UVM Health Network board of directors, I'm not seeing enough ownership over their role in the whole state system, if that makes sense. And I've yet to see that. I look forward to that change.
How confident are you that the Green Mountain Care Board can get this under control?
Well, I don't think we're in a situation where business leaders, community leaders, and others can sit back and wait for the care board to just do it all on their own. I think that from my talking to Owen Foster and others at the care board, they definitely understand the crisis and are worried a lot about how to turn the ship around. But they, even though they're a powerful board, a powerful regulator, there's not, they have a limited set of tools in as much as, they sort of check in on these hospital budgets once a year. Last year, you saw them trim the increase that the UVM-MC could have, and the reaction was to cut services. There's nothing that prevents that gives the board power to say you cannot take the budget down by affecting X, Y, and Z. And so that's where the community pressure, I think, is important. And that's where Vermont Healthcare 911 is trying to help people understand just how bloated the network's overhead is. They're really top heavy. They're not spending more than their peers on patient care. They are spending far more than their peers on admin and management. And that's what needs to change. The Green Mountain Care Board can't change that all on its own. They have some of those tools to do that, but public pressure is important for us to really right-size that ship and or force a culture change where leaders in the hospital system and their boards of directors decide to take on that challenge on their own. Ideally, you'd have the regulator and hospital leadership working together to come up with a vision for their own hospitals and the state, and it wouldn't have to be combative necessarily. I think it would be far more productive if hospital leaders came to the care board in a more cooperative stance and said, here are the bottom lines for us. Here's where we can give. Here are some ideas we have. Here's what we're doing to tackle and change some of this system. That to me would be exciting and should be possible, particularly in a small community like Vermont. We're not seeing it yet, and we're doing everything we can to kind of force that conversation.
What does public pressure mean in this situation? I mean, what can John Q, Jane Q public actually do to effectuate change with an organization as large as the UVM Health Network or even the Green Mountain Care Board?
Well, as having lived in Vermont for a long time, Mark, as long as I've been in Vermont, and probably a lot longer, everybody knows everybody. So if you're a business leader in Vermont, I'm going to guess you're one or two people separated from somebody on the board of the University of Vermont Medical Center or the Health Network, or somebody, your neighbor knows Steve Leffler, who's the CEO of the medical center. Those are as important as the work that we're doing to try to get these stories into the press, that people can testify in front of the Green Mountain Care Board. But that social pressure, that turning to your friend, turning to a former colleague and saying, hey, you sit on this board. Why do I keep hearing that they're losing so much money on Medicare patients, for instance? I think that's more powerful than people sometimes understand, because people get on these boards not because they want to do good. They want to serve an important institution. They want to give back to the community, but it's complicated and it's hard. And in most cases, they're not paid to be on the board. And people like me are saying, you got to do some hard work. You've got to really dig into these details and start asking tough questions. So that's where, that's what I mean by public pressure. And I think business leaders have a great potential, so far mostly untapped potential, of coming forward and demanding. I mean, after all, they're the ones paying these high premiums, most expensive in the country. Where's the outcry from there? We're trying to generate some of that. We're talking to business leaders all the time. But as an example, there's real potential in the business community as one example of folks who could step out and really vocalize to their friends and to their neighbors who who lead the hospitals or serve on the boards, this is unacceptable. We've got to turn this around.
That wraps it up for this edition of 802 News, sponsored by Red Hen Baking Company. Thanks for listening.